Calcium channel blockers in hypertension. Calcium channel blockers are a diverse class of drugs that lower blood pressure and manage heart rhythm by preventing calcium from entering the cells of the heart and blood vessel walls. Two major classes. Calcium channel blockers are broadly classified into two major classes based on their predominant site of action. The first group is the dihydropyridines, represented by amlodipine and nifedipine. These are potent vasodilators that act primarily on blood vessels, making them particularly effective for treating hypertension. The second group is the non-dihydropyridines, including Verapamil and Diltiazem. These drugs act more specifically on the heart, reducing heart rate and cardiac conduction. Mechanism of action. Calcium channel blockers inhibit L-type voltage-gated calcium channels in vascular smooth muscle and cardiac muscle. This reduces the influx of calcium ions into cells. What happens when calcium is blocked? In vascular smooth muscle, calcium is essential for muscle contraction. Blocking calcium entry prevents contraction, resulting in vasodilation and a decrease in peripheral resistance, which lowers blood pressure. In cardiac muscle, calcium blockade reduces the force of contraction, producing negative inotropy. It also slows impulse generation and conduction through the SA and AV nodes, leading to negative chronotropy and negative dromotropy. Therapeutic uses. Dihydropyridines, amlodipine and nifedipine are potent vasodilators that act predominantly on vascular smooth muscle with relatively lesser cardiac effects. Because they produce marked arterial vasodilation, they are among the most commonly prescribed drugs for hypertension. They are also effective in chronic stable angina, where they reduce afterload and myocardial oxygen demand. Another important indication is Raynaud's phenomenon, where their vasodilator action improves blood flow to the fingers and toes, relieving vasospasm. Therapeutic uses. Non-dihydropyridines, Verapamil and Diltiazem act more specifically on the heart by slowing the SA and AV nodes and reducing heart rate. Therefore, they are particularly useful in supraventricular tachycardia and for rate control in atrial fibrillation. They are also effective in angina, where they reduce heart rate and myocardial oxygen demand. In patients with asthma, they serve as a useful alternative to beta blockers, which may precipitate bronchospasm. Critical warning. Non-dihydropyridines must not be combined with beta blockers, as both suppress the heart and can lead to severe bradycardia or heart block. Adverse effects. Dihydropyridines commonly cause peripheral edema, especially swollen ankles, due to arteriolar vasodilation. Patients may also experience flushing, headache, and reflex tachycardia resulting from the fall in blood pressure. In contrast, non-dihydropyridines predominantly affect the heart and may cause bradycardia and AV block. Because they reduce cardiac contractility, they can also worsen heart failure. Another characteristic adverse effect, particularly with Verapamil, is constipation. Key takeaways. Calcium blockade produces vasodilation and, in the heart, reduces cardiac output, together lowering blood pressure. Dihydropyridines act predominantly on blood vessels and are used mainly for hypertension and angina. In contrast, non-dihydropyridines act primarily on the heart, making them useful for arrhythmias and rate control. Finally, remember one important key safety rule. Do not combine non-dihydropyridines with beta blockers, as both slow heart rate and AV conduction increasing the risk of severe bradycardia, AV block, and heart failure. Understanding this class distinction is essential for the safe and effective clinical use of calcium channel blockers.